So our next speaker is our very own Jeff Curtis. Jeff joined us a number of years ago from Oregon Health Sciences University, where he had done his medical and training and his residency and came as a rheumatology fellow. Already with one master's degree, he quickly earned another master's degree from the Harvard Clinical Effectiveness Program, and he's now working on a third master's degree in clinical informatics. So Jeff has really risen through the ranks as currently our William Koopman Professor of Medicine, an international star in large database work, clinical informatics. He's running a large subcontract to the Patient-Powered Research Network at PCORI, a very important interaction that he'll discuss. And it's really a pleasure to have Jeff here. I want to mention one other thing that is quite current. Each year, the Department of Medicine figures out the overall impact of the research portfolio of all the faculty using a self-derived metric. And this year, Jeff was the #1 professor in the Department of Medicine in that metric. So it's a real pleasure. And Jeff, welcome, and look forward to your comments.
Well, thank you very much, and I appreciate the segue because, in fact, measuring adherence could be a whole talk, and in fact is. So, so thank you for teeing that up. And I don't have any conflicts of interest except my role as the co-PI of the Adult Arthritis Patient-Powered Research Network that's part of PCORNet. So this is what we're going to discuss a bit about for the next half an hour or so. We're going to talk about how we define adherence, various ways we might measure adherence, a little bit about a comparison between methods, just giving you one empiric example, and then to talk a bit about outcomes and foreshadow how we might think about improving adherence. So I'm going to draw an example from my own field in rheumatoid arthritis, and the details are a bit less important, but it just is intended to help motivate why measurement is so critical and how a physician in clinic really may be quite disadvantaged in doing this. So let me just tell you the story, and I'll narrate sort of the details for non-rheumatology people. So 29-year-old woman who has seropositive, meaning blood test positive, new onset rheumatoid arthritis. She has high disease activity based on a metric we call the CDI, so that would be a high number, meaning she has very active disease. You know, maybe she can't drive carpool or pick up her daughter because she has 20 or 30 tender and swollen joints. She gets started on a drug methotrexate, which would be a very common first-line therapy. It's a drug that affects the immune system. It's used by oncologists in much higher doses to treat malignancy. We use it in rheumatology for a variety of conditions, including this one. So it's dose escalated over a couple months. She gets better, but she still has somewhat high disease activity. We add a biologic drug called adalimumab or Humira. This is a cytokine drug. It's about $3,000 or $4,000 a month. These may be direct-to-consumer ads that you've seen on the television for that or drugs like it, where you have patients skipping through the fields with butterflies, and then there's the rabbit droppings of safety at the bottom that you could get histoplasmosis, tuberculosis, dye, lymphoma, etc. Those ads. So her disease activity gets quite a bit better, but 6 months later it seems to worsen, and she switches drugs to this, the doctor switches drugs to this different biologic, and things kind of are touch and go, and she has a bunch of flares, and then 2 years into the disease, she has new erosions on an x-ray, her hands are starting to turn and look like this, and she's starting to wear, bracelets and assistive devices, and starts wearing copper on all of her joints to try to prevent this. So this is not that uncommon a story, regrettably, but to sort of narrate between the details, she hasn't started this, quote, chemotherapy drug. She looks on the side effects on the internet. Whatever the top 5 Google searches is of course, absolute truth. She takes only half of her methotrexate because she feels so crummy. It causes nausea. It causes mouth sores, and in fact, it really does. She skips 1 out of every 3 doses of this injectable biologic drug because she hates giving herself shots. And then she was feeling better, so she quit taking that injection medicine. She didn't really think she needed it. And then she switches therapies, but she takes it on demand, and she lengthens the dosing interval rather than taking it once a week. Maybe she misses 1 out of her 4 monthly doses, and then she's discouraged that, now she's having to change all these drugs and she has really bad disease. So, from the doctor's perspective on the left, there's a whole backstory here that he or she just has no clue about. But she doesn't want to be disadvantaged if, the doctor thinks that this is a bad patient not doing what they're supposed to, so she may never be quite forthcoming if she perceives that there's going to be a lot of censure and a lot of negativism that she's met with to really, express those fears. So this is my second favorite quote. Ken stole my first favorite quote about medicines, but from William Osler. So the desire to take medicine is perhaps the greatest feature which distinguishes man from animals. So that might be true, but I actually feel like I contend with the opposite problem much more often in clinic. People are plenty happy to take lots of prednisone for years and even ask for narcotics, but don't want to take medicines that really treat severe immune system diseases. So let me just give you a sense to think about a framework for adherence in relation to what the physician may know or in fact may not know. So if you look at just the pattern of drug use in the domain, so patient hasn't started the medicine, the doctor is sort of thinking about why might this patient be non-adherent in the future? And there's probably some clues clinically that a doctor has a sense of. If you have a list of 12 medicines that you're intolerant to for, somewhat nebulous reasons, the likelihood that patient's going to be intolerant to the next one's probably high. But if she never starts taking it, then the physician probably will know about it. Primary non-adherence. The medicine was prescribed, but the patient never filled it. And at the next visit, the doctor can ask, did you ever start? And the way I ask that, I try to be very non-judgmental. I actually just ask, were you able to start the medicine, trying to make it okay that the answer might be no? And I just set that up, just not to make the assumption. How did you do with that medicine, which of course makes the assumption that she started it? Don't make that assumption. Make it okay for her to say, you know what, I really just didn't feel comfortable about that. So to talk through that. Secondary non-adherence. So the medicine was prescribed, the patient filled it, and they're still on it, but they missed some doses, like in my example. The doctor may or may not know about that. A different form of secondary non-adherence, so they started taking it, but the patient just totally stopped. The doctor, if he or she asks, are you still taking it, likely if the patient is totally discontinued, the doctor will know about it. And then there might be times when the patient quits taking the medicine, and that could be appropriate. They're in clinical remission, or the doctor says, hey, you can stop taking this. I'm putting you on a bisphosphonate drug holiday, but depending on what your data source is, if it's pharmacy data, you don't know reasons why people are doing things in a lot of cases. So the data source is very critical to think about, which type of problem are we dealing with? Is this a physician awareness of non-adherence? In which case, if the doctor knows about it, then they can remediate it potentially. But, who's aware of this? And is this intentional or unintentional? Or does the prescriber know about this? Or does he or she not know about it? So the other factor that plays into a lot of this is social desirability bias. If you're getting ready to tell the doctor in 5 minutes, because you're filling out a questionnaire in clinic, you're not taking your medicine, you don't want to be seen as a bad patient. You don't want to have a confrontational visit with that provider, so you may not be entirely forthcoming. And there's been a number of studies where, patients are asked by a doctor, a healthcare provider in the clinic versus via a computer or, even via a questionnaire at home on the internet or the phone. The more impersonal that you can ask that question about whether you're taking medicines, probably the more accurate an answer that you are going to get, just because of this fear that you don't want to be perceived as a bad patient and not taking your doctor's advice because they're going to be mad at you. So one has to think through some of those issues. There have been a variety of questionnaires or instruments, and I've given you a handful of examples. The Mariski may be the best one known, and there's an 8-item measure of adherence, and then there's a reduced 4-item scale. There's a few others, like the Beliefs About Medication questionnaire. There's one specific in rheumatology, the Compliance questionnaire in rheumatology. So I gave you a couple examples just so you can see what's in them, and then perhaps critique them based on what's in them. So there's a necessity scale as part of this Beliefs About Medication questionnaire, and I won't read them all to you, but the idea is do you need the medicine, yes or no? And then there's concerns. What are you worried about? Having to take medicines worries me, etc. And people answer this. But when you look at this, you say, well, without my medicines, or will depend on my medicine. This is the wording. Well, what medicine are we talking about? Are we talking about, your biologic drug or your ibuprofen or prednisone? This lumps together a lot of things. It treats medicines as one thing, and yet lots of times patients don't see it that way. It's not all one thing. This is the medicine that makes them really nauseated. This is the medicine that causes some other issue or that they're worried they're going to get cancer for. So this is one of the limitations. It just lumps a bunch of things together and calls it medicine. And yet if what we care about is are you taking this particular drug, because that's the important one, the statin that reduces your MI risk, for example, this may be too general. This is long and busy, but this is the one that's rheumatology specific, where some of these questions are quite extreme. I definitely don't dare to miss my anti-rheumatic medications. I don't know who worded that, but that's atrocious in my opinion. Or, I don't expect miracles from my anti-rheumatic medicines. I'm not even sure what people envision by anti-rheumatic medicines. If you can't stand the medicines, you might say, throw it away no matter what. I mean, some of these things you think, gosh, this is incredibly artificial, and how did that wording come to be? But nevertheless, this is a validated instrument. But it still has the same problem on the previous scale. Medicines are lumped together, and that may not get you what you're after, which is the patient taking this medicine at this moment in time? So then that really sets us up for defining what is adherence. And ISPOR gave a definition, the extent to which the patient's behavior prescribes with, coincides with the prescribed treatment regimen, time, quantity, frequency, and then it comes up with some definitions to quantify things, both in compliance and persistence. So there's a couple definitions of adherence that have been around. This one's sort of foreshadowing some operational definitions. So this has been operationalized in a couple ways. So compliance, which sometimes is used synonymously with the word adherence. Compliance is a little bit out of vogue. It's felt to be a bit pejorative, and that you should probably use adherence. But my main point here is really make sure that you know what you're talking about and what the other person or what you're reading as they're using these terms, because different people use these terms sometimes interchangeably, or you might think they have a specific meaning, but they're actually used quite differently. So one of the ways that adherence is calculated is using a metric called the proportion of days covered. So you take a new user of therapy, you calculate the number of days that a drug was given. Perhaps if this was pharmacy data, this would be how much is dispensed, making the assumption the patient takes it. And then in the denominator of this calculation is the time since starting a drug. So for example, if you looked in pharmacy refill data and the patient had filled 300 days of medication, and they did that over 365 days since the first prescription among a new user, then you do the math, and that's 82%. So that would be a proportion of days covered, or PDC, of 82%. Now again, that assumes that you found a new user, so because that's a big deal, there is definitely time-varying nature to adherence. If you just take persistent people, past persistence, past adherence is a really good predictor of future adherence to that drug and others. The other metric that sometimes gets confused is a medication possession ratio. So the idea there is that the denominator isn't time anymore. It's the interval of time between prescriptions. It's not calendar time. So, between the first and the last prescription, look at how much drug that the patient had on hand. So the problem with that is that if calendar time isn't in the denominator, as it is with the PDC, it can be very misleading. So for example, the patient fills a prescription for 30 days today, and they fill a prescription in 1 month, and another one in a third month. They have 100% adherence, but then if they totally stop, then they take no medicine for the next year. So you have 100% MPR, because again, the denominator is the interval of time between the first and last prescription, but really ignores the fact that the patient discontinued after that third prescription. So it's important to recognize that how these are calculated has actually a big bearing on the kinds of data that you will compute and how you estimate things. Another way to look at it is to quantify persistence as the length of time since you start a drug until you quit taking it. So usually you define a permissible gap. So, if you've been without medicine for 30 days or 45 days or 90 days, it's a little bit arbitrary. And the longer that you go out, which allows people to restart, you'll get a somewhat different answer. So you might describe a result like this. The median persistence on a drug is 94 days, or 58% of patients were persistent at a year, meaning they didn't have a gap beyond some length, but what that gap interval is not entirely well quantified. In the field, you have to choose, and ideally you hold all the drugs to the same standard. The counter-argument is, well, what if you have a 30-day supply for some drugs and a 90-day supply? I mean, you have to think about some of those sorts of things. So these are complementary. If you're measuring one of them on the top, that doesn't exactly tell you about the one on the bottom. So both metrics are probably useful depending on what the drug is, what your question is. And you have to think about switching and restarting. So this is a persistence curve for methotrexate among people who have rheumatoid arthritis. So what you'll see is by about a year, roughly half of the people start, and we start to get into some censoring here. So one might walk away and say, well, 50% of people quit taking the drug within a year or are non-persistent. What this doesn't tell you, though, but that is actually true in this analysis, half of those people who quit subsequently restarted within the next year. So if you just put blinders on and sort of don't look beyond that, you just say, well, here's when they're non-persistent, you'll miss the whole story, that many of these people had a gap, maybe they felt ill or the doctor could lower their dose. So there's a little more to the story that you have to dig to use data like this pharmacy data in an effective way. So that's a drug that eventually makes people feel better, or at least gets their arthritis doing better on average. So we did a study where we looked at adherence to multiple drugs in essentially asymptomatic diseases: hypertension, hyperlipidemia, osteoporosis. So here the y-axis is a medication possession ratio, or a proportion of days covered, greater than 80%. So basically over about a year, roughly 3/4 of people remained with this very high level of adherence. But what we did here is we allowed you to get credit for any drug class whatsoever. So for example, if you started this beta blocker, you switched to a different one, we gave you credit. So you have to ask the question as a researcher, are you interested in adherence just with this particular drug the patient's starting, or is it enough to be adherent within a drug class? And if you're using a drug like hyperlipidemia therapy, where probably you're only on one drug at a time, it's likely fine to say, let's look at adherence just within the class. For an antihypertensive, where combination therapy is pretty common, that may not be good enough, depending upon what your question is. And adherence wasn't optimal, but you'll see that basically these curves are almost superimposable, suggesting that no matter what disease state we're talking about, adherence here is bad. For some of these others, like depression drugs, thiazides, it's a bit worse. And then glaucoma medicines, where it's even worse than that, although some of that, it may be related to formulation and just how much you're supposed to be taking, because this is pharmacy data, and it's hard to measure drugs that are given as drops, because you don't know exactly, how many drops the patient's supposed to be taking. So if you quantify a medication possession ratio in a quantitative way, looking across different categories, you'll often get a distribution like this that looks bimodal. So an MPR of 80% to 100% means basically you're taking most of the drug most of the time. You've got a good group of people here that is taking the medicine quite regularly, and then these are the people that take 1 or 2 doses and then probably give up. So this is a very common pattern that you'll see. And then there's a handful of people that are erratic for a variety of reasons. And this is a gout study, but probably we could show any chronic disease. So there's a lot of ways now, if you said, well, I really want to know, are you taking this particular drug, that one might figure that out. So we've talked a little bit about patient diaries and patient self-report. As part of our PCORNet patient-powered research network, we're using some mHealth tools to be able to allow patients to track that on smartphone devices and build a medication reminder system so that they can do that, so that we can look at that for research purposes, but then also build in useful tools to help patients remember to take medicines if that's useful to them. Physician report is probably the poorest of any of the things that are on this list. How does the doctor know if the patient's taking the drug? He asks the patient, are you still taking the drug? So that mostly is going to get to persistence. But it's much harder in the clinic to say, have you missed any doses at all over the last 3 or 4 months? Well, yes. Well, how many? Well, I don't know. So physician report is generally quite poor compared to some of these others. You could get pill counts from return bottles, and I agree with Rive that, if the patient says, yeah, I'm not taking it for any of these methods, or you get a whole bunch of pills back, great, then probably you have high certainty. But there's nothing to prevent the patient from just dumping it all out in the trash right before they show up at the clinic visit. There's variants on smart pill bottles, or caps, or prompts, or reminders, or blister packs that have some sort of electronic interface. So those have some cumbersomeness and certainly some expense, but those work to some extent. Pharmacy data, I've showed you a couple examples from different pharmacy benefits managers or health plan data. I'll speak a bit to electronic health record data, since that's getting more and more accessible. Some, but only a minority of drugs, have drug levels that one might be able to directly measure. And I'll speak a bit to ingestible biosensors. And then for a very small number of drugs, we require directly observed therapy, like for TB treatment. But of course, that's exceedingly cumbersome and intrusive. So electronic health record data is getting more and more available to researchers as well as to clinicians, to mine for clinical care, for quality improvement, and for measurement of adherence. But there's some pitfalls compared to people who even are very familiar with using claims data from pharmacy databases. So it records the medications as written, but not as dispensed. Doctor writes the prescription. We have no idea whether the patient ever filled it. Depending on the drug, maybe 5 to 20% of first prescriptions for a new therapy are never filled for a variety of reasons. You do get information about the number of refills written, so again, you know the maximum number that the patient could refill, but you have no clue how often they actually did refill it. Certainly in most health systems electronic health record, you rarely have stop dates. You don't explicitly know for a lot of medicines, and there's medicines that the patient hadn't been on for years in my own practice that the nurses just are supposed to keep updated, but doesn't happen. So you're often missing explicit stop dates, but yet I look in the record and they're on a totally different drug, but that does the exact same thing, and there's no way that they can be taking both of them. Sometimes, but not always, you'll get over-the-counter medications captured, but it's quite haphazard. I work with drugs that are given intravenously sometimes, like biologic drugs, where that's actually not on the pharmacy package. You have to go to a whole different package that our health system just purchased recently, so you don't have intravenous medications except in this other part of the EHR, and you have to know to go look for it. Those are medical procedures. You can sometimes impute discontinuation if other drugs are used in a mutually exclusive way. So, what's the likelihood somebody's on 2 simultaneous statins? Probably not very high. Or in the arthritis world, 2 simultaneous biologics. That's not going to really happen generally. So you can probably assume that the first one got stopped when the second one was started, but that's actually a fairly uncommon scenario. And finding new users is challenging. The idea that you have pharmacy data, you have a 6-month or 12-month clean period where the patient had pharmacy benefits, you don't see prescriptions for a drug, and then they have a new filled prescription. That's a pretty standard way to define a new user in pharmacy data. You don't get that in electronic health record data. What's to prevent the patient from seeing the doctor for the first time and gets that prescription? You don't have any data prior to that. And there's some tricks you can use to try to look for visits or other drugs filled in that health system, but it does make a few assumptions to find new use of any therapy in EHR data. You don't get the idea of a denominator like you do in pharmacy data, where if you would see a claim for a filled prescription, great. If you don't, it means it wasn't there. In electronic health record data, you have no such guarantee. And then perhaps the more novel one is ingestible biosensors. So I've blown this up like crazy, but this is about the size of an 800 milligram ibuprofen capsule. And this basically is a radiofrequency ID tagged sensor that is embedded within this gelatin capsule. When it gets in your stomach, it uncoats, and then it can talk to a sensor device that the patient would wear. And then that data goes to a HIPAA-compliant cloud-based server. And then there's a synchronized interface. So it seems like these are safe. Whether patients will find this an acceptable thing, if we thought the NSA was bad, this takes us to a whole new level. Why will people do this? Is this really going to be okay for our medicines to be laced with metal, etc.? The component size is small, 1 by 1 by 0.3 millimeters. That's more than 3-fold smaller than capsule endoscopy. So it looks big, but it's not. But I think that the acceptability to patients is actually a much bigger issue than even some of the technical problems. So then let me switch to a comparison between methods, and I'll just give you one empiric example from what I think is a quite elegant study that our colleagues here, Paul Muntner and Alessandro Colantonio, did. So they used a cohort study called REGARDS. This is a large study that's a national stroke study that's coordinated here at UAB. So there were multiple sources of information. Patients are asked by questionnaire whether they're taking a medicine. There's a medication inventory that's done in the house. Go bring me all your pill bottles for somebody standing in the patient's home. And then this data was linked to Medicare data, including Part D drug coverage. And so the data was compared with the computer-assisted telephone interview and then the in-home visit. And there was a relatively small gap, like less than 45 days, between these in some of the main analyses. So you're comparing 3 sources of information: what the patient tells you on a phone survey, what a person in the patient's home that says, go bring me all your medicine bottles, and then writes those things down, and then what we see in pharmacy claims data. And the interest was to look for agreement, recognizing there arguably is not exactly a gold standard. So there's a lot going on this slide, but I'll direct you mainly to the two rightmost columns. The overall agreement was roughly 85%, and the agreement adjusted for chance, or the kappas, is about 0.7. So, good but not perfect. If you then make a more specific comparison, so no Medicare claims data among the participants who are using lipid-lowering medication. So these are people using lipid-lowering drugs like statin therapy based on the regards data, either with the medication inventory or the self-report, and the y-axis is the percent of people who don't have a claim in the pharmacy data in Medicare for a drug. And you might walk away that about 15 or 20% of people are using a therapy for antihyperlipidemia treatment that we can't find a claim for. So, the claims data is simply wrong. But then if you go the other direction and you say, well, what if you start with people who don't have a lipid-lowering medicine in the cohort study on the registry or the cohort side, but that have Medicare claims, it's about 15 or so percent. And here the y-axis is they're not using a lipid-lowering medication based on the regards data. So the bottom line is that these things generally agree pretty well, but they're not perfect. And there's a lot of reasons for this about, are you using samples? Did you forget? Did you stop? Did you not know that you were on, that this medicine was to treat high cholesterol, etc.? So agreement is good, but don't expect perfection. And in fact, there's not even complete agreement between the in-home visit data and what the patient said on the phone questionnaire. So triangulating all three sources, you don't get complete agreement. So why aren't people more adherent? And obviously, we've already thought about that some, but just to give you some sense of perspective coupled with data, some of these reasons, as I think about them, they're not modifiable. The drug didn't work, or the drug caused intolerable side effects. This may not be very remediable in terms of trying to improve adherence. So I think about this sort of as the marginal patient. If the drug doesn't work, there's nothing to intervene upon because they're not going to stay on it, nor should they. If the drug causes some terrible side effect, then there's nothing to intervene upon. So I might put those people in a different category. It's the other people who have potentially modifiable reasons. There's cost issues. There's patient beliefs. Is the drug needed? Is it likely to work? Does it help you feel better? Do I need to be treated at all? Are you afraid about safety? So we just finished a direct-to-consumer social media project, and the overwhelming evidence was that people were much more frightened, or at least they tweeted and blogged with much more concern about medicines they saw on television that were advertised than anyone was very optimistic that this was going to provide a lot of improvement for them. And then there's other factors based on, physicians' interactions, trust, and, what some of the logistic options are. So, not surprisingly, the reason for past adherence or non-adherence really affects future non-adherence. So this is an arthritis study where if the drug didn't work, and that's why you switched from the first biologic therapy for your rheumatoid arthritis, you are much more likely to discontinue the next one because it didn't work. But if you stopped because of some toxicity or side effect, you are much more likely to fail the next one for toxicity or side effect. So, past performance does really affect future results, despite what your stockbroker might say. But perhaps more interesting than that is your beliefs about whether this drug, in this example methotrexate, is needed and whether you have concerns about it was much more related to whether you're likely to have low adherence. So if you believe that the drug is necessary, you are much less likely to be non-adherent. And if you're not at all worried about it, then again, you're less likely to be non-adherent. So again, patients' beliefs about the medicines, how much they need it, how much that it's going to help or cause harm, is very relevant to future non-adherence. So we talked a little bit about the health belief model, and I realize it's been around there for a long time, but I would agree with you that I don't think we've optimized any of this stuff, at least not in the rheumatology field. So we have very little data on what happens if we undertreat some of the diseases that I deal with. So, your perceived susceptibility and severity, very few patients think about the risks of not treating your disease. They'll only see the risks and benefits of the medicine sort of in isolation, but fail to consider what are the risks of undertreating or not treating whatever bad disease that we're giving you these medicines for. And, I somewhat jokingly say, I have every respect for your dentist or your oral surgeon, but if you break your hip, you will not go back and see your dentist. rheumatologist. So, they're very fearful about, ONJ or jaw issues with bisphosphonates, but sometimes they fail to see, well, what are we treating? We're preventing hip fractures or other fractures with osteoporosis therapies. So think about the counterpoint of what's the medicine that we're using to treat actually putting you at risk for, because sometimes people fail to recognize that. And I think we've done a crummy job communicating that. So we also often fail to quantify risk and benefit very well. So, just some informal surveys, asking rheumatologists, well, how do you describe some of these medicines and their side effects to patients? I'll very, very commonly get, well, I tell patients that the risk is low. Well, I don't know what that means, and neither does the patient. So just for fun, I've asked people who come in, often with concerns having reading medication guides or seeing something on television, it says that the risk for tuberculosis is one of the concerns. How common do you think that is? And invariably, I'll get a number like, 10%. So this person believes that, 10% of people starting on the arthritis drugs I'm recommending are getting tuberculosis. It's about 1 out of 1,000 people. So, if you have no clue and have no frame of reference about how bad any of this stuff is or how likely it is, then even though these models have been around a while, I don't think we've operationalized them in the clinic very effectively. And then just a few things about outcomes. So the first, this is just a representative study that looked at the disease activity scores we measured in arthritis between persistent and non-persistent patients. So the question invariably comes up, what is the minimum level of adherence to be able to get the best or the maximal benefit? It's often phrased like that. But what you're really asking is did the company who makes this drug and sort of the studies used to dose it get it wrong? Well, assuming that they mostly got it right based on phase 2 or phase 3 data, you should be pretty close to 100%, which I think is why people choose to dichotomize adherence, because you mostly better be taking most of the drug, because otherwise the dose is just way off. So I'm not sure how relevant it is to even worry about, how much adherence is enough to get the benefit, because that's really going back much earlier to phase 2 dose ranging studies that the FDA is quite keen on making drug companies prove, what's the lowest effective dose, and wants dose ranges at the higher and lower end. So I think it's appropriate in most cases to mostly dichotomize persistence, and this showed that if you were not persistent in yellow, you had a higher disease activity level in arthritis, and this has been shown in other contexts with even sort of lab measures like the SED rate and the CRP. If you had low adherence in blue, you had significantly higher inflammation markers for these people with arthritis that had low adherence to the arthritis medicines. Gout is kind of an interesting therapy when we use allopurinol and drugs to lower serum urate. So in the group that has medication here in black, the y-axis is your flare rate or your attack rate. As you are changing people's serum uric acid levels, they actually may have more attacks, or at least they'll have ongoing attacks for quite a number of months, maybe like out to 6, 9, 12 months before this eventually gets to a relatively low plateau. The relevance is that if you think you're starting this new gout drug and you're going to not have any gout attacks within a month or 2 or 3, think again. So you have to counsel patients about what to expect, that there are going to be some differences. This isn't going to start working immediately, because otherwise they're going to say, I don't feel any better, I'm still having attacks, the medicine may not be working. That's some provider education and time up front to be able to help the patient understand what the expected course of benefit is, and this clearly is not within a month or 2, everything looks great after starting this urate lowering therapy. And then one of the last few ideas I want to leave you with is that there are a lot of bad outcomes associated with adherence. And this is an observational study that Monica Safford and I worked on, where we're looking at the Women's Health Initiative, and we're looking at the hormone therapy arm of this, so the HT interventional arm. And what was found in this study is that there was a significantly lower all-cause mortality and about a 50% lower risk for hip fracture and lower risks for other outcomes like clinical myocardial infarction as assessed in the WHI. And that was true even after controlling for a whole bunch of stuff that you can't read here on the bottom, but that the WHI collected and measured at the beginning. But the thing that I found interesting about this study is that this is adherence to placebo. This isn't adherence to hormone therapy. So this is blinded placebo adherence, and it's associated with a 50% lower risk for hip fracture and favorable outcomes on all these other things, despite the myriad of things that the WHI did a great job adjusting for at baseline. Now, so my point is there is this idea of a healthy adherer effect or a healthy adherer bias, that there are certain factors associated with high adherence that you may or may not be able to measure effectively. And despite controlling for a lot of these measured confounders, there may well be a lot of unmeasured confounders that you can't capture. Now, subsequent work that we did that went on to elucidate what was going on really looks like this is a sick-stopper effect. So the WHI observation period, of course, was many, many years for most of these women. So as women were getting sick and having other events, they would quit taking medicine, and that's why they're not adherent. But to capture that, you really have to look at competing risks and what's happening over time. You can't just adjust for baseline factors. And once you look at that, then mostly you can undo this effect. So, what works, and in some sense that's much of why we're here today and the rest of the conference. This is just a partial list about what we might do, and I think we're going to chat a lot more about, but just a little bit of foreshadowing. One feature that Monica and I are very excited about is the Patient-Activated Learning System, or PALS. So this is something that's an informatics project that we've been working on really to help improve adherence, recognizing that information for patients is often whatever Google comes up with, and what friends and family tell them, and is often not happening within the confines of the provider's office or even part of the healthcare team. There's a lot of questions that may or may not ever get voiced for reasons of embarrassment or time or whatever, and that current approaches to information are really falling short. So we are developing the PALS system, which is a national web-based educational resource that you can really just ask questions, or it's a search engine that has a searchable knowledge base. This is something that patients could use at home, you could use in a waiting room. It's not content specific, and it doesn't retrieve for you, pages and pages of articles. It's really intended to be very focused. You ask a question, it gives you an answer. You don't have to wade through pages of text to get your answer, and it would adapt over time to get smarter. And so we're very excited about that. And Monica has gotten some grant funding to look at this as part of a trial. So we're thrilled about that opportunity to, again, help plug one of the gaps where people are operating based on misinformation. So just to summarize, long-term adherence to medicines is poor, but how we measure it, whether the provider knows or not, whether it's intentional or not, is obviously quite critical. And we have to figure out whether we're interested in adherence to a treatment regimen or a class of drugs or specific therapies. And improving it clearly is challenging, but I'm excited that this conference will help provide some suggestions and collaborative opportunities. So thanks very much.